Hello, everyone. Welcome back to the ACHD Hive talks. My name is Dr. Bouchard. I'm the ACHD Hive founder. And we start the year with an important session on pregnancy in ACHD patients, an important topic with new ESC guidelines. To explain these guidelines, we welcome Dr. Lorna Swan, followed by a discussion with Magalie Ladouceur, and participants are absolutely welcome to ask any questions, raise please a virtual hand first or write in the chat. So with no further ado, Lorna, thank you so much for helping us out on this session.
Melissa, I think you need to let me share my screen.
Absolutely.
So give me a shout when you can see this.
We can see.
Yeah, so thanks everybody. So I'm going to just talk about the new ESC guidelines that were released in summer of last year, and really just from a cardiologist's perspective. I'm not going to go into a lot of some of the obstetric care, which is really important, but I'm just going to focus on us as cardiologists, what is probably new or interesting. So I'll touch very briefly just on the writing process, and just that was quite an interesting thing to be part of. And then I'll go through some of the newer components of the guidelines, and I'm going to focus on these things here. So the spectrum of conditions. We'll talk about some of the new components, so primary arrhythmic syndromes, some of the new scenarios, the clinical scenarios that are embedded in the guideline. I'll talk about mechanical valves because I think that's always an area of controversy, some of the new infographics, and then we'll talk a little bit about how we counsel the most high risk patients. And just at the end, I'll just give my own personal perspective on I think what we sometimes miss when we're just looking at guidelines. So these were all the authors of the guidelines. As you can see, it's a very equally split group of people from different countries, different um, healthcare models, mainly based in Europe, but you'll see there's also folk from the US, for example. And I think writing the guidelines, two things that really struck me was one, how different our practices in different countries. Um, and I think we have to kind of appreciate kind of two things. One, that guidelines are only an overview of a topic. So unless you want to write a textbook that's 200 pages long, they are really just giving you the kind of first introduction to subjects. And also, again, we have to remember that guidelines are written for a general audience. So I think if you're a generalist, these are super helpful. If you do this every single day and have a very large cardio-obstetric practice, you may find that the guidelines are sometimes not answering some of the more difficult questions that you have. So let's just go through the spectrum of conditions that are in the new guideline. So as you'll remember, the first guidelines very much came from a congenital heart disease background, and that's where many of us were practicing. But as you can see now, there are now big new sections really covering all of the topics of cardiology. Specific, there are new recommendations, things to do with, for example, post-transplant, some of the cardiac devices that are becoming more common in our patients, and new groups of patients that we're now seeing, for example, very gene-specific recommendations about things like aortopathies. So I would say the breadth of conditions covered is much greater than before. As well as the breadth of conditions being much greater, also the depth at which we discuss patients has changed. So here's the old guideline looking at hypertrophic cardiomyopathy, just as an example. So you can see if you look at the risk tables, and remember risk goes from low risk to very high risk, all of the hypertrophic cardiomyopathy patients were placed in this middle risk group. If we look at the new guidelines, you can see that this is now much more nuanced. And I think it reflects the patients we see. So for example, we're now getting referred patients who are gene positive but have a structurally normal heart from our imaging, and we can be reassured that they are down in a low risk group, and right up to some of these hypertrophic cardiomyopathy patients who've got quite significant hemodynamic complications. So I think the risk tables, although they fundamentally have the same structure as before, give us a lot more detail for our individual patient. Other components that are new are we've really updated some of the new drug tables. Unfortunately, some of the newer drugs we're using, so for example, some of the newer drugs we're using for hypertrophic cardiomyopathy or for heart failure, by definition, these are new drugs, and therefore we have limited knowledge of the risks of these drugs in pregnancy. And that does mean that a lot of our newer drugs, which have revolutionized treatment of heart failure, are not drugs that we have any good safety data on in pregnancy. And therefore, at least at the moment, are drugs that we're saying we cannot use during pregnancy. So it's worth having a look at the new drug tables. Again, risks change with time. And just to compare some of the newer drugs that we are now saying are safe either during pregnancy or on this side of the chart during breastfeeding. So one of the areas that's changed quite dramatically is the primary arrhythmic syndromes. And I say if you practice in this area, I think we're seeing more and more of these patients. There are now recommendations for all of these for long QT syndrome, for Brugada, so for the CPVT, and a very brief comment about short QT, which is obviously very rare. And I think one of the good things about the guidelines, these are very practical. So they'll talk about what therapies you can give your patients during pregnancy. They'll also talk a little bit of general background about what other treatment options there are out with pregnancy. They've included the links for drugs to avoid if you have long QT, drugs to avoid if you have Brugada. And then let's just have a wee look over here, just very practical things. So they tell us, for example, in long QT, that actually the period of increased risk is postpartum. They talk about the safety of Nadolol, which is something we can give during pregnancy, but potentially not so ideal in breastfeeding. They talk about things to avoid during pregnancy, for example, hyperemesis. And they talk about what kind of screening there should be of the neonate and what genetic testing we should do. So they're very practical additions to the old guideline. Similar for Brugada, similar for CPVT, and really they're very honest that in short QT there's really not much data, at least at the moment, but again, a rare condition. One of the things the guideline wanted to do is to be more clinically relevant, and it is now full of lots of nice infographics and scenarios that you can turn to and use as a reference if you are facing a patient who's got an issue. And they've included a really quite robust section on arrhythmia management. So here's one of the algorithms, and again, I think we all look at the pictures rather than reading the text, but here's one of the algorithms for atrial fibrillation or atrial flutter. And again, it'll just talk you step by step through what first line treatment is, which is obviously cardioversion if somebody's unstable, and then what our first line drugs would be and what our second line drugs would be. So very practical, something in an emergency you can very quickly turn to and read rather than having to read a lot of text. I'm not sure about your own practice and how many patients you're all seeing, but one of the questions that comes up very frequently is about the management of pacemakers and ICDs. And this just reflects that we're starting to use more devices in, for example, our patients with congenital heart disease or our DCM patients. And it just talks about how to optimize these patients pre-pregnancy, during pregnancy, and particularly at delivery. Our anaesthetic team get quite concerned about patients with the devices, and they really want quite specific recommendations about what to do, how to program the device, what to do in an emergency. So again, nice simple algorithms for practical problems that we face very frequently. So let me just briefly focus on mechanical valves. I think this is an area that we find really very challenging. So these patients are at the high risk of the group 3. So they're not in group 4, so those are the patients at extreme risk, but they are definitely at this higher end risk of the group 3 patients. And you can see that is giving a maternal cardiac complication rate of somewhere around 40%. Just to highlight, that group is related to patients who have uncomplicated mechanical valves. So mechanical valves that are working well, they don't have heart failure, and they are fully engaged and have good INR control. When we look at this guideline compared to the previous guideline, unfortunately, we're not doing any better looking after these patients. So if you look at the data from ROPAC, and there's a 10-year gap between these two studies, only about 50% of patients are having an uncomplicated pregnancy with a live birth. So although we've had the old guidelines for many years, we're still not very good at giving these patients a good outcome. And why is that? Well, it's for this triad here, as you know, maternal thrombosis, which we worry about a lot in terms of valve thrombosis and stroke, maternal bleeding, and poor fetal outcome. So the guideline is really very much based on a lot of the data that have come out of the most recent ROPAC study. If we look at just the regimens we use most frequently, you can see here the problem very quickly. So if we look at the vitamin K antagonists, they have lower rates of thrombotic events and lower rates of hemorrhage, but they do, and although this part is not statistically significant, they do come at a higher fetal and neonatal complication rate with miscarriage and poor neonatal outcomes. And that's the inherent difficulty for us when we're prescribing for these patients, maternal versus fetal and neonatal outcomes. We've got some nice new algorithms to tell you how to manage these patients. They have changed quite a lot since the old guideline, and let me just highlight a couple of the ways in which they've changed. So if we look at the top here, again, we're really highlighting the importance of having someone who's fully engaged with good INR control before a pregnancy. So much so that if a patient doesn't have good INR control at baseline, we're really saying those patients are in group 4 and need to consider alternatives to having a pregnancy. So these are exquisitely high risk patients. If you can't have good INR control before you get pregnant, we're going to really struggle with you being pregnant. Class 4. The other thing that we've kind of really embedded in the guideline is this whole box here of how do you stratify risk. If you remember from the old guideline, we really focused on the dose of warfarin. So we said, if you've got a low dose of warfarin, keep it going. If you've got a high dose, think about an alternative. What we've added into this box, I think, is really important, and that is the whole idea of maternal choice, but also just trying to work out what is the risk of your patient having a valve thrombosis. The understanding being that if you've got a high risk, then you really should be staying on your warfarin. What is high risk? Well, you can see at the bottom there, it's things like having a valve that doesn't work perfectly, maybe having even more than one valve, having a mitral valve or an older valve. So you're taking the risk of thrombosis, the warfarin dose, and maternal choice to decide how you're going to manage these patients. In reality, if they're at high risk, then that probably means continuing their vitamin K antagonist. And if they have low risk features, maybe a big dose of warfarin and fully informed maternal choice, then you might think of an alternative like low molecular weight heparin with dose adjustment. See, this is now something that's being pushed more than ever, that the safest thing is probably continuing with the warfarin or Coumadin. Another of the algorithms that is new, and hopefully this is not something that's going to happen to you, but just really what to do if your patient arrives in labour and they're already anticoagulated, be that with vitamin K antagonists or some form of heparin. And again, practice will vary a little bit in your country and also vary according to the protocols your own haematology department have, but giving you practical advice about what to do. The box at the bottom really just highlights a recommendation for everybody, and so not just those who've arrived in anticoagulated, and that is about when we restart anticoagulation after delivery. So they strongly recommend that after delivery, you postpone that switch back to oral anticoagulation, and obviously a time when they're double anticoagulated, till at least 7 days after delivery. That will mean the patient potentially staying in hospital for a bit longer, and I think you have to, at the beginning of the pregnancy, warn the patient that they will not be going home very quickly after their delivery. Why do we do this? Well, because we've found out that wound healing and things like cesarean section, hematomas, these are a big problem when we're trying to restart oral therapy. So again, just a red flag about something to be careful about. So here are all the recommendations for mechanical valves. The reason I've put these up is just to say these are all based on expert opinion. And again, it's an area where we're really needing more evidence base and more research to tell us how to manage these patients. Are these backed by hard science? Absolutely not. They are consensus and the best guess, but to improve outcomes, we need to get some more data and some more hard evidence about how to progress. Let me just run quickly through a couple of the new infographics. So there's some lovely infographics that give you a lot of information very quickly. Say if you don't have time to go through a lot of text, I've just pulled out one looking at aortopathy, and there's a really nice, much more robust section on aortopathy. You can see we're now at the kind of level of detail where recommendations are almost down at genotype level. So different recommendations for different types of lowest deets, for example. So this graph just shows you some recommendations about when you would think about surgical intervention before a pregnancy. And you can see for some of these patients, so way down at 40 millimeters, for some of the kind of more concerning lowest deets patients. You can see the opposite is true, much more relaxed about the bicuspid aortic valve patients. And then at the bottom is about mode of delivery. So again, as you know, for most of these patients, we are encouraging vaginal delivery, but there are certain sections where sometimes for logistic reasons, sometimes for hemodynamic reasons, a cesarean section might be more appropriate. So have a look at some of these nice infographics. Here's a very practical one, good for your accident and emergency department or your ER. And this is just about how to manage patients with chest pain. And again, as you probably all know, there's a triad we need to remember when we're thinking about cardiac disease. That's acute coronary syndrome, pulmonary embolism, and acute aortic syndrome. So as you can see again, written for generalists, practical, and stuff that you could put up on the wall of your emergency room. The last thing I want to talk about before I just talk a little bit about what is missing is just about our class 4 patients. So remember, those are the patients who are at the very highest risk and who we will counsel to suggest they might want to think of alternatives to carrying their own child. And if they do present in early pregnancy, we'll have some kind of quite challenging discussions. As you can see, there's a little bit of a worry in that if we look at the old, through some of the ROPAC studies, although we're getting better at some things, so for example, we're getting better at treating heart failure, the number of these high-risk patients is increasing. So we're seeing more and more of these high-risk patients. So in the old guideline, and this is where it was really useful in the guideline to have patient representation. In the old guideline, some of the language we used was probably quite paternalistic. So we talked about things like pregnancy being contraindicated. And it was very interesting to get the patient's perspective of not finding that language very helpful. What we've moved more to is more a patient-centred vocabulary in the guidelines about what matters to the patient. Now, this highlights the need for expert counselling, either pre-pregnancy ideally or in that very first visit when the patient discovers they're pregnant. This doesn't mean we shy away from discussing termination or shy away from being very honest about risk, but it does need to be a conversation rather than a didactic recommendation. So I think the whole tone of the guideline has changed to be more about what matters to the patient and an expert discussion about the pros and cons of continuing with a pregnancy. Finally, just from a cardiologist's point of view, something I wanted to kind of suggest that I think sometimes guidelines don't get the full picture of. In the guidelines, there's a lot of discussion about risk, and we have these lovely risk tables now where we are allocating risk groups, and you've heard me talk about them already. We'll sometimes use the CARPAC score too. But what often gets your patient in trouble is not this. What gets your patient in trouble is the interaction between, go backwards, this and this. So this is cardiac risk, and all of this is the psychosocial background of the patient, the healthcare system you're in, and the obstetric and fetal complications. So you may have someone who's a relatively low risk CARPAC score and a low risk WHO 2.0 score. But if you add in, they've got a high BMI, they're not really engaging with care, they have a degree of social disadvantage, and they develop preeclampsia, often that is what causes complications. And again, the guideline is a cardiology guideline. It doesn't focus on a lot of the obstetric risks, but sometimes the obstetric risks are more important to your patient than the cardiac risk. Patients are often more concerned at having a very preterm baby than they are if they have to come in and have a cardioversion for an arrhythmia, for example. So just in summary, those are the things I think from a cardiac point of view that are really useful. I haven't focused on some of the obstetric things, and I say they talk particularly about some of the long-term impact of having an adverse pregnancy outcome and some nice new sections on things like hypertension. But see, that's just my perspective on a little cardiac update on the guideline. So thank you for listening, and I'm looking forward to hearing your thoughts or questions.
Thank you, Lorna, for this excellent presentation. Very helpful and very clear. And I'm also happy to introduce Professor de Baquet, who is the professor in cardiology in Ghent University, and she is the chair of these guidelines. And she's an expert in ACHD and heartopathy. Thank you, Jolie, for being with us.
Yeah, and I want to apologize wholeheartedly for missing the timing. I got called by one of my patients, and yeah, you guys know how this works. Yeah, there was no way around it. And Lorna, you did a great job. I couldn't have done this better than you did. I joined you halfway through your presentation, but thank you for picking this up and for giving this presentation.
C'est la vie.
Well, yeah,
we have to
unfortunately,
we have priority. Don't worry. Can I start by any challenging question about prosthetic valve in pregnancy? Because as you know, we have many women with ACHD and multiple previous history of cardiac surgery, and some of them may require a new surgery of valves, and many times it's aortic valves. And we always discuss with our surgeons about the type of valve we have to indicate if it's a prosthetic metallic valve or a biological valve. And my surgeons, and I would be very happy to have your opinion about this. My surgeons say, these patients underwent 5 or 6 sternotomies, and it should be the last sternotomy. It's why we decide to implant a metallic valve, even if the patients would like to become pregnant. How do you deal with this type of situation, which are quite challenging?
Magalie, who would you like to answer the question?
Yeah.
Do you want me to go first, or Julie, or
Yeah,
who would let
thank you.
Julie go first?
This is a very difficult question, Magalie, but it's a very relevant question. First of all, I think these situations where you will have a mechanical valve implanted in women with ACHD, or the need for a mechanical valve, these are rare situations, for sure. I think these are and I think you need to take many aspects into account. I've been talking to people in different parts of the world, and I think you need to take into account the resources that you have in your center, or the options that you have in your center for correct monitoring. So there's places in the world where like anti-10A monitoring is not so easy, or it's not feasible, and you need to take that into account as well. If you can provide good monitoring and good follow-up of these aspects that are needed for correct management of these women, then yeah, I think you need to take that into account. And of course, and I think Lorna has also expressed this in her presentation, this is all about shared decision making as well. You need to talk to your patient in the first place and explain her what the risks are, and what the options, and maybe even alternative options for fulfilling a child wish. I mean, you need to talk to them, and talk them today, and maybe again next week. It's like I had to do just now. Some of these discussions you will not be able to come to a decision after one consultation. So I think you need to take this on the individual basis. Again, I well, maybe this is my personal opinion. I don't think it's wrong to put in a mechanical valve. It's not because we have in the guidelines that you should prefer the option of a biological valve. This is not something that is written in stone. And there's, if everyone agrees, the surgeons and the patient and you, that the mechanical valve is the best option, then you should go for that option. It's well, that's my view. I don't know how the others think, but
I had my, but hi, Julie. I had my first case as a consultant was a patient who was in her 40s, and it was discovered to have an aortopathy. And so we had to get to that conversation about operation. She was pregnant. It was a very difficult situation, but I thankfully I had Magalie who was here to advise me. And yeah, I think the key to that was open communication and conversation with the patient about, do you want another child? But then, where would that take us in terms of that decision? Or and actually, I find that it's quite a stressful time for the patient, but particularly because then they have to make that decision, and sometimes they don't. As you say, you don't want to make that decision in one clinic. They want to come and see you again in 3 weeks. I've thought about it. It's really, but I completely agree that it is about conversation and communication, and it's okay to change your mind before, or but it's true that if you have, the whole team has to be behind you. The surgeon has to also want to be on board. So
yeah,
Lorna,
I think it's
yeah.
Okay, so I think it's really difficult, and I think as Julie says, it really depends on your service, how good your surgeons are, what resources you've got. The other thing is sometimes you're asking folk who are teenagers to make decisions that are going to affect the rest of their lives, and whether they have children or not. And your views when you're 17 and you're 30 are by definition almost going to be different. Sometimes you have no option, particularly if you're talking about mitral valve disease, particularly mitral valve disease that's presented early in life. You often have no choice. I guess transcatheter valve interventions opened up a bit more options, but again, that's not available everywhere. So sometimes what we'll do now is we've got a young woman, we will maybe give her a tissue valve, knowing that that tissue valve is not going to last a long time, but we could then do a TAVI or a transcatheter valve and maybe give her another period of time, enough to have her children, and then to have a definitive operation. But those are really difficult, complicated discussions about risks of redo surgery. And so, as I think everybody has said, that's not a quick conversation. And there isn't a right or wrong answer. I mean, if I said to my cardiac surgeons, you can never put a mechanical valve in a patient, they would laugh me out of the room, because it would just show that I don't really understand. Sometimes there is no option. So yes, I think it's easy to write a recommendation and say, oh, you shouldn't put a mechanical valve, but that's not real life.
Yeah.
I just wanted to ask all of you, actually, because Lorna, you mentioned that we're seeing more and more high-risk patients. Why do we think that?
I guess one of the issues is that our treatment is now so good. So, for example, pulmonary hypertension. Now, with good pulmonary hypertension treatment, people feel well, they feel good, and therefore they're saying, well, I'm back to normal. Can I have a baby? You go, well, you're back to normal because you're on 2 agents for your pulmonary hypertension. I think also we've moved a wee bit away from a very paternalistic view of just, no, you can't get pregnant. So people ask the question. The area I'd really notice it is we've now had such good heart failure medication that even people who had terrible ventricles, their ejection fractions are looking much better. They feel completely normal, but they're not. And you're going to have to take them off some of these drugs for a pregnancy. So they are having high risk pregnancy. So I think it's a kind of multifactorial. Be interested to see what other people think in other countries. That was ROPAC data, which is, I guess, would suggest that we're noticing that in different countries. But I'd be interested to see what other people think.
I would like to know, because in these new guidelines, there are more data on breastfeeding and medication. And I would like to know if you, in your experience, you have decided about a type of medication for arrhythmia or orthopathy according to the hope of the patients to feed her baby, or if you recommend to avoid breast feeding if the patients need a medication that can be in the milk.
Yeah, I think again the discussion needs to be with the patient about risks of in some cases there may be risks of breastfeeding. In other cases, like I'm thinking about women with heart failure, where once they have delivered, you will absolutely want them to be on their heart failure drugs to improve their outcome. And many of these drugs, well, some of them at least, are not suited for lactating women. But we within the group we have had these discussions about the topic of breastfeeding. Again, we need to consider that policies across the globe are not everywhere the same. In some countries, prohibiting women from breastfeeding might have very serious effects on the outcome of the baby. So you also need to take that into account. And again, it is not up to us. It's like Lorna was saying, we moved away from this paternalistic way of practicing medicine. It's not up to us to forbid anyone also from breastfeeding. So I think you really need to carefully take into account the risks that are known, and I mean, we had a very good pharmacologist in our group who taught us a lot actually. But what I remember also from these discussions, that for many drugs there is like no data. I mean, especially when you think about the newer heart failure drugs, and there's no data, and well, it's very unlikely that there will ever be any solid data. There's never going to be a randomized controlled trial giving a group of women the standard heart failure treatment and let them lactate and the other ones not. So that's a bit of a general problem, I can say, we had in developing these guidelines, that for many issues, and especially also in the setting of lactation, we lack data. There's some animal studies and there's some calculations that you can do about what ends up in the milk, but still you don't know what effect that will have on the developing baby. So I know, and I realize, Magalie, that we are maybe not giving any concrete or solid answers, and I'm fully conscious of the fact that in our guidelines, well, we have, like, I don't know, 90% level of evidence C, but that's what it is. It's yeah. There's no way around this, which does not mean that you not need to discuss this with the women again, but and taking the individual situation into account.
Yes, but the new guidelines, I'm very happy by the new guidelines because they provide simple infography on treatment that can be provided during pregnancy and during breastfeeding for arrhythmia, for example. And it's very helpful for us when we don't know what type of beta blockers or other antiarrhythmic treatments into these patients. And it's why, even if there is not enough data, it's a beginning and it's very helpful for us.
Thank you. Thank you, Magalie.
I don't know if you have in the audience some question. Do not hesitate to ask them.
I wonder if I could ask a question. So Julie, I'm really interested. So obviously you've been traveling quite a lot and talking in different parts of the world about the guideline. Anything in particular that struck you, or anything that you were kind of surprised about when you've gone to different parts of the world?
Well, yeah, I've been traveling. I'm not saying that I saw all parts of the world, but interesting discussions that we had, and we also had this webinar with the ISAC, where many people from across the world were present. Yeah, it is always eye-opening. I mean, especially when we think of the situations of rheumatic valve disease, which are situations that in our Western world we do see them, obviously, but we have way less experience with those situations than our colleagues in other parts of the world have. Not just about management of pregnancy, but also considering that in some parts of the world, patients, women or men equally, will only have one chance for surgery. There's only going to be one situation, and you want to have a one-stop situation where you can have, well, not a complete, but a complete as possible repair of the lesion. Not thinking about redo surgery, because there's no way that this will ever happen, and there's parts of the world where, like, for example, surgeons are not even trained to put in biological valves. So you need to consider this, and also, and I mean, I live in a country, I live in a very tiny country, and you can, in Belgium, you're never, I think you're never further than 30 kilometers away from the nearest hospital. and you can get, well, let's say quite proper care in most centers. This is completely different from, and you don't even need to go to low income countries. I mean, go to Canada or even, I mean, in France, there's like these islands where there's no medical support in big regions, and these are also things that when you go talking at other places, that you come to realize that we should be conscious of the fact that we live in a small bubble, and that what we think is most appropriate. Also, when you discuss issues like pregnancy termination in some part of the world, and you don't need to go very far for this. This is not even, you cannot even consider it. And when we think about our colleagues at the other side of the Atlantic, there's I've heard like terrible situations where you can, even as a healthcare professional, end up in jail when you even think about discussing prenatal termination, whatever. So these are things that I have encountered since I've been talking about this. But I'm sure, Lorna, that you have also had similar experiences. It's
I think it's two things that come to mind. I think it's easy to think that what we see is the whole picture, and our way of doing things is right. And I think it's really good. It was really good on the guideline to have people from quite diverse countries and systems. I think that really adds something. And as you say, getting the opportunity to go to other parts of the world and to have to interpret the guideline for the reality of what's there I think is really valuable. I think we learn a lot. I think also there are some countries who are much better at doing things than us, in terms of, she talked about the treatment of rheumatic heart disease. If I was pregnant and needed my mitral valve ballooned, I would really like to be in India and not in Scotland, just because they have so much more expertise and experience. And the other thing that kind of strikes me is what you mentioned about logistics. So even in Scotland, well-resourced country, universally available NHS care, but we have little islands in Scotland. If you have a mechanical valve, and we're thinking about low molecular weight heparin and regular anti-TENI levels, if you live in a small island in Scotland, particularly if it's in the winter, that's just not going to work. So you're going to have to either stay on your warfarin, or you're going to have to come to the mainland for care. So guidelines can't write about everything, but these kind of logistic things and some of these healthcare things are actually a deal breaker in terms of making decisions.
Yeah, exactly. I fully agree.
This is really interesting. So, I mean, I find the guidelines so pretty to look at, as in you they're very clear, and like you, as you said, Lorna, you could see them on the wall, and they should be in A&E even now in Germany. It's not because you're in a big developed country that the doctors that are treating you necessarily know how to treat a pregnant woman or a postpartum woman with cardiac disease. And so that brings to my point of education and how important educating the cardiology trainees, the cardiologists, and everyone else that works in emergency care. I think it's really important as well to promote the subspecialty. And I wondered if we could finish actually the session in you all telling us what made you decide to subspecialty in pregnancy and cardiac and ACHD patients. What drew you to these patients? Julie, do you want to start?
Yeah, sure. And I mean, I think I'm speaking for many others. I've been I started working with the ACHD like 25 years ago when this was still in development. I mean, at our institution, pediatric cardiologists still took care of these patients and did that. They actually trained me in a very well way. And I think from the perspective of ACHD, many of us have saw these patients come into a situation where there's a pregnancy desire, and it's kind of logic that you move also in the field of pregnancy, because yeah, you need to at least try to provide the best care possible. So it's not something that as a young cardiologist I had in mind. I'm going to do pregnancy care as one of my subspecialties. It's a matter of opportunities, serendipity, if you want to call it that way. It's things that come your way, and it's in my case it was kind of organic, which does not mean that I don't. I think that there's actually room for proper education, as you say, for proper training. We have, well, the world is different now than 25 years ago. So, and I would be very interested, and now that we have these experts here, I would be very interested. Like we've been very strict in or strict. We put a lot of emphasis on the importance of pregnancy heart teams. I would like to know that in what centers across. Let's start with Europe, but even beyond the European borders, what centers do have a pregnancy heart team in place, and how does it work? There's not that much data about this. It would be very interesting, I think, to explore this and to see where these centers are located and how maybe we can set up some form of education or training, or I would be interested in that, but I don't know if Lorna and Magalie would agree. I'm happy to talk about this. Maybe not today, but some other time.
I follow your opinion. It's true that education is very important in pregnancy as well as in other topic. Like it's not the topic today, but for example, heart failure in ACHD, we need to sensitize our trainees in cardiology, and it's true for cardio-obstetric, and probably I can explain for my country. I think there is not enough training on cardio-obstetric. We start something now because we have these guidelines and they are very important and very well structured. But we need more in the program of trainees in cardiology, because there are more and more facing to these patients, these young women with cardiomyopathy, with as well as hypertension during pregnancy, and we need to follow them after. It's very important. We know now it's cardiovascular risk factors. There is more and more conscience of health in women, and pregnancy belong to health in women. I totally agree with Julie, and I think to have a survey to know which country has a program, a training, how cardio-obstetric teams are organized. It's very, very interesting according to me.
So I agree with what folk have said. Back to the original question. So again, I came from an ACHD background, and your patients are becoming pregnant and asking about pregnancy. And I think one of the things that attracted me to this area was you're really working as a multidisciplinary team. So it's the only time I physically sit in clinic with another consultant clinician. So I'll sit in the same room with the obstetrician. We'll do our preconception counselling stuff together. We'll do our antenatal care together. And that teamwork is, I think, is one of the most, for me, one of the best parts of cardiac obstetrics, and working in other specialties that you're not an expert on. And if I try and be an obstetrician, it'll be a disaster. And if they try and be a cardiologist, it's a disaster. So really working together with each other's strengths. To the general piece about just general education, I don't think we get it, at least from where I work, get it right. We've got a lot of cardiology trainees. They can't all come to the very specialist clinics we have, particularly things like some of the complex pre-pregnancy counselling. So it is about doing webinars and seminars and teaching days. And I think we've been really lucky that the ESC have got a pregnancy and heart disease guideline. But obviously other parts of the world, like the US, for example, have been kind of a bit further behind. So I think that is great because it gets it on the radar of your average general cardiologist. But I think we've got lots to learn, and it's nice we can write all these lovely guidelines. But in reality, yeah, how many top end that can deal with everything? Pregnancy heart teams have you got in your country? I think that would be interesting to know that, and I think that's probably the next phase of us trying to improve care, isn't it?
Yeah, from experience training in the UK, I don't think I ever had one lecture on cardio obstetrics. I discovered it when I moved to the Brompton, and we did pregnancy clinic there. But as a general cardiologist, before I got to ACHD, it was never even on the curriculum. It is now. How they teach it and how they assess it, I'm not sure. But yes, it would be really interesting to see who has a pregnancy heart team and how they train their team. Well, we're just on time. It's 1 o'clock. So thank you so much for joining us for this really special session. I will write a little conclusion, but it seems like communication with our patients was the highlight. Working as a team, and potential thoughts on doing a survey on pregnancy heart team around the world. Thank you so much all. I'll stop the recording now, but thank you.